A laryngospasm is the body's protective reflex to irritation of the trachea and vocal cords. This complication is common in the oral and maxillofacial surgery office, where treatment is performed in the mouth, and where irrigating solutions, bleeding, and other foreign bodies can lead to tracheal irritation. Laryngospasm is approximately 3 times more likely to occur in children than in adults. The best way to avoid a laryngospasm is to prevent it from occurring. Oral and maxillofacial surgery teams must be constantly aware of head position, airway patency, effective suctioning, and placement of a throat partition.
Let's pack off the surgical site. Can I have a glass, please?
Yep.
See if I can advance her tongue here. I still don't hear. I think I hear some crowing. I think she's got a laryngospasm. Let's see the suction. I've got the surgical site packed off.
The degree of laryngospasm must be rapidly determined to provide appropriate treatment. If the laryngospasm is incomplete, inspiratory crowing may be heard. In this case, the team responds by properly positioning the airway, packing off any surgical site, thoroughly suctioning the oropharynx, and applying 100% oxygen by full face mask until the laryngospasm breaks.
Okay, she's getting easier. I think we've got it broken.
In the case of a complete laryngospasm, no inspiratory noise will be heard, but often the patient will have a paradoxical movement of the chest and abdomen, indicating aggressive attempts to breathe. The team responds to a complete laryngospasm by removing the throat partition and packing off any surgical sites. Then the team suctions the oropharynx and hypopharynx of any debris. Next, position the airway and extend the tongue as needed. Apply a full face mask with 100% oxygen and attempt to ventilate. Listen for evidence of airflow. A solid push on the chest may create outflow from the lungs. Retrieve the emergency cart and turn to the laryngospasm algorithm. Retrieve the succinylcholine and give a subintubating dose, 10 to 20 milligrams. If the spasm breaks, support the patient until spontaneous ventilation occurs and the patient is stable. If the spasm continues, deliver a second, larger dose of succinylcholine, 20 to 40 milligrams. Remember, the second dose of succinylcholine can lead to bradycardia, so a dose of atropine is appropriate prior to this. Rocuronium is an alternative to succinylcholine, which can be administered at a dose of 0.6 to 1.2 milligrams per kilogram. Because its duration is much longer, be prepared to ventilate the patient for a prolonged period of time until return to spontaneous respiration. Laryngospasm summary. Signs and symptoms. Increased respiratory effort. Difficulty in exchanging air. Inspiratory crowing sounds, partial spasm. No inspiratory sounds, complete spasm. Treatment. Stop the procedure. Administer 100% oxygen via nasal mask. Suction the oropharynx, hypopharynx, and nasopharynx and remove all blood, saliva, and foreign material from the oral cavity. Pack off all surgical sites and suction thoroughly. Draw the tongue and/or mandible forward. Deliver succinylcholine if necessary. Support the patient's airway until spontaneous ventilation returns.